Well, I want to thank everybody for being here today. For those that are online, thank you for being online as well. And we are here in a town called Waite Park, Minnesota. If you don't know where Waite Park is, join me, all right? But it's near St. Cloud. That's easier to find. They're like areas that touch each other. So we are up here to do another Compass MS Care program, and I want to thank everybody again that's online. I want to thank our exhibitors that were here, but I want to thank our supporters. We had EMD Serono, Genentech, Novartis, and TG Therapeutics, and I'm hoping everybody in the room can thank them as well. Let's give them a round of applause. Thank you. Those supporters of our program helped to make this program happen. All right, so we just want to, like I said, I wanted to thank them. We have Dr. Calkwood. Nobody wants to hear me talk. Let's talk about Dr. Calkwood. I don't have a lot to say about Dr. Calkwood except that he's an outstanding neurologist. And we started having Dr. Calkwood speak years ago, and I'm glad we did. And I'll bring him around the country if we can get him out of his normal day, but that's very difficult to do because he's got a lot of patients to serve. But Dr. Calkwood is the chief medical doctor at the Minnesota Center for Multiple Sclerosis. Come on up. I'm not talking much about you. I got to get you started. Thank you, Dr. Calkwood.
Thank you, sir. First of all, thanks to the sponsors, because none of this would be possible. It takes money to make this kind of stuff happen, and people like Stuart going around the country. You have to check out his YouTube channel. If you haven't looked at, you will be blown away by all of the information. Many speakers, my friends in the world of MS and colleagues, Stuart knows everybody in MS. So, and thank you for doing this, Stuart. So. And for all of you who are coming out tonight. So I just want to tag on to what Stuart said about the navigators. I think that's been one of the most important interactions between my patients and the MS Society, because the navigators get down and dirty, they get their hands dirty, they get into people's lives, they help you. They can, we use them for so many things, coordinating with county social services to help find what services might be available in your area you might not be taking advantage of. There's just the healthcare insurance for medical insurance. So I'll move that up a little bit. Excuse me one second. So if you want open enrollment time, if you have questions about your insurance and you need to get new insurance or look at options, MS Society can help you with that. There's so many things that they can do. So as Stuart mentioned and Kathleen did, please take advantage of that, of what the MS Society has to offer you. So tonight I get to talk to you about a bunch of stuff. We'll talk about some symptom management. First of all, make sure I can work this thing. So that's so we're going to talk about how I can't imagine anyone here doesn't personally have some experience with fatigue and MS. Even if you're a caregiver, you see what it does to your loved ones. So fatigue, a huge problem in MS. Pain management. I'm going to tell you a little story on myself about pain management. And then I really want to focus on some of the emerging treatments, and we'll look at the classes of treatment we have, but some of the emerging therapies coming along, and we've had kind of a recent disappointment, but I'll go into that, and we dust ourselves off and brush ourselves off and keep moving when these disappointments occur in clinical research. So I guess I should probably take this point in time. This is a brand new lecture. I built my old one, was a little stale. So, I'm exploring the world of AI as the younger people seem to be doing right now, and I don't want to get left behind. And so I was working on having doing some of the graphics and some of the images. And so this was I said to ChatGPT, create me a cartoon of a neuron that's fatigued. That's what we got. Okay, not bad, not bad. And just pay attention though. It gets a little weird, and some of them I was going to get rid of, but they're kind of funny, so I'm going to include them. And the one at the very end, I'm just going to say the word cars. So the very last cartoon I show you, think cars. It's actually about CAR-T therapy. So anyway, a tired neuron, fatigue. It is the silent symptom of MS that has the single biggest impact on people with MS day to day. When you hear the, oh, but you look so good, people don't understand what you're going through. And they definitely don't understand the impact of fatigue on the lives of people with MS. So it's hugely important. Now, there are some things I'm really going to focus not on the drugs we can throw at it. We'll talk about that, but on what you can do to help yourselves. So there we go. Now, this one is a little spicy. So here I was saying, what about a neuron that's just exhausted? And then the too tired to fire came up. So we understand the prevalence. I've mentioned this. Now, what I didn't get, I don't know if you guys can see, this is supposedly a cell body of a neuron. And these little things are dendrites. And then these two dendrites are doing something they're making it a little saucy. And I assume these are like coronaviruses and various other things assaulting the neuron in the background. So too tired to fire seems to be an apropos statement for what people with MS have to live with. So we know there's a huge impact. We know up to 80% of people, 90% of people have fatigue from MS. 80% it's activity living, at least at some time. 60% it's activity living daily. And the impact is disabling, even more so than mild physical symptoms. Fatigue can push people out of the workforce, affects families, affects interactions, affects your life, your quality of life. Now, we'll get into this a bit more, but there's fatigue due to MS, and there's the fatigue due to other things, and they play off each other. So to try to understand fatigue, we need to think about kind of the different types of fatigue. So we have the fatigue associated with MS. It's primary fatigue. It's caused by MS. We don't exactly understand where this fatigue comes from. We know in part the primary fatigue of MS is related to maybe certain areas of the brain that are affected. The frontal lobes, the reticular activating system is an area in the brain that's responsible for alertness and attention. So a lot of these physical structures in the brain have been implicated, yet we'll see people with profound fatigue who have no lesions in any of those areas. So it's more than just that. We don't fully understand what primary MS fatigue really is or where it comes from. Now, we do understand more about motor fatigue. Motor fatigue would be the physical exhaustion that you have when your legs just weaken. If you're exercise a little or even walking to the mailbox or transferring, going from your bed to the bathroom, you may fatigue, and that's a physical fatigue that seems to be coming almost directly from spinal cord involvement. So spinal cord is a really big piece of the physical mobility fatigue that we see in persons with MS. Now, secondary fatigue isn't related to MS, at least not directly related to MS. So secondary fatigue can come from lots of things. I'll show you a few other examples on the next slide. And then we have this on this side, tiredness. Well, tiredness and sleepiness. There are things besides there are neurological conditions, narcolepsy, various other disorders where someone suddenly becomes profoundly fatigued, even just like falls asleep. That would be more narcolepsy. Multiple sleep latency tests can define that. So sleepiness is different than fatigue. And sleepiness may have organic causes in your lifestyle. If you're not sleeping well, maybe you have restless leg syndrome or some of these other secondary neurological symptoms. So here's some of the primary and secondary causes. If we're thinking about primary fatigue, and again, what I'd point out is all of these causes of fatigue overlap and magnify each other. So if you have primary MS fatigue and you have tiredness because your circadian rhythm is all messed up, you're not sleeping well, or maybe you have sleep apnea, or maybe you have restless leg syndrome, your legs are moving around in your sleep. You may not be aware of that, but it's disrupting your natural sleep patterns. So when you wake up in the morning, you've been in bed with your eyes closed for 8 hours, you wake up in the morning, you're not rested. So lots of things go on in sleep, and so we need to be aware of that. So teasing these things out are the first step to treating the underlying problem of fatigue to make it better. So if you are depressed, there might be medications. Maybe you're anemic. These are things that aren't directly related to your MS, or maybe it's a medication that is related to your MS. Gabapentin we might be giving you for tingling and numbness that could actually be increasing your fatigue. So we have to look globally at all these things. Nutritional, if you're not taking in enough calories or not the right types of calories. If you have respiratory issues, shortness of breath, COPD, thyroid problems. By the way, thyroid problems are one of the most common overlap diseases overlap autoimmune diseases we see in MS. Up to 30% of people with MS are going to develop thyroid problems. We can measure the blood in antibodies in the blood of people with MS and see antibodies against their thyroid gland. More than 30% of people have those antibodies in their blood if they have MS. So very common problem. Fatigue is the #1 symptom of hypothyroidism. So we can't just focus on the MS part. We have to tease all of these out and understand what they are. And each of them can be treatable in and of themselves. Now, in order to tease this out, we have to measure it. And in part, this is important for studying treatments in clinical trials to say we want objective measurement systems. So some of these scales, visual analog scale, modified fatigue impact scale, just a fatigue severity scale, all of these are things that can be done mostly in clinical trials or in some cases in the setting of an MS center. In a general neurology practice, you're not going to see a neurologist be really able to do some of these things. So keeping that in mind. Now, the modified fatigue impact scale is a really important one because it will actually help us split out those physical fatigue issues versus a cognitive versus psychosocial. So that's a questionnaire type form that will help identify if there's something more going on maybe in your social life or your sleep hygiene and how you're getting to sleep. Anybody here have a TV in their bedroom? Well, a few people willing to admit it. Do you actually turn it on and watch it in the bedroom? You know, bedrooms are for two things. One of them is not watching TV, okay? So that's an example of sleep hygiene that we really, there might be a third thing, never mind, let's not go there. So sleep hygiene is about this, it's about having a natural wind down before, read a book like in paper, that doesn't have blue light in your eyes, and get the TV out of your bedroom. It doesn't belong. Put it in the living room. That's a better place for it. So, and again, in order for us to target with either therapies or with in research of new therapies on treating fatigue, these scales are really important. They're not the end all. You guys have the ultimate fatigue scale. It's every morning you get up, right? Chronic fatigue syndrome was all the rage for, a decade or so ago, and they're having all these chronic fatigue workshops. And they'd always start these workshops. Can I borrow your water there for a second? Every day you start out with an 8-ounce glass of water, and that's the energy you have for the day. And you need to parse that out. It's fine, unless you have MS, because every day is different, right? One day you got 2 ounces in that glass. The next day you got 6 ounces. Maybe you get a full glass, but part of some of the self-help things we're going to talk about, you have to learn to listen to your body and what your body is telling you on that day. When we talk about exercise, it's even more important. So, many things to think about. Jump to the medications. Well, hope, turns out medications for fatigue management aren't all that effective. There was a meta-analysis. Meta-analysis is where a researcher will take all of the other studies and put them all together and try to kind of even them out, because each study studies things a little differently, and then try to pool these up so we have large numbers. In that meta-analysis, the medications didn't really do so well. Amantadine, modafinil, armodafinil, amphetamines aren't necessarily FDA approved, but we use them a lot for MS-related fatigue. But while those were the most effective of some of the medication treatments, the single most effective thing in this meta-analysis, actually several studies have shown this, numerous studies, is physical exercise, cardio, or otherwise daily activity levels. Really, really important for managing one's fatigue. So drugs can help. Now, these drugs aren't necessarily, some of these are direct stimulants. Amantadine is a Parkinson's drug, but it has a side effect of sort of stimulating wakefulness. So we use amantadine for its side effect. Modafinil, armodafinil, those are for sleep-wake shift disorder issues, people with sleep apnea. Amphetamine salts, well, we use those for lots of things. Now, dopamine drugs, the Parkinson's drugs, and amantadine has a little bit of that effect, have an impact on restless leg syndrome. So sometimes, and by the way, if you have restless legs, check your serum ferritin. Get your primary care doctor to check a blood test called a ferritin level. And if your ferritin level is low, not even low like in the below the normal range, but if you're in the lower part of that range, 75 or below of a ferritin level, your restless leg syndrome might be treated almost completely effectively by an infusion of iron. Iron is really important for making dopamine, and dopamine is that neurotransmitter involved in restless leg syndrome and fatigue. Anticholinergic drugs we might be using for a bladder. I have told patients this. I am going to make your fatigue better by giving you a bladder medicine at night. And they go, say what, Willis? Yeah, no, not so much. Well, if you're getting up to go to the bathroom 3 or 4 times a night, or even if that's arousing you out of a deep stage of sleep that you need to feel refreshed in the morning, then if I treat your bladder, you'll have less fatigue. So now, this is really about thinking about the whole person rather than just let's throw a medicine at this or a medicine at that. So, and as we go through this, think more and more. What are the non-pharmacological treatments we can use? I already mentioned exercise right at the top. Other things that we might be able to do, I'll talk a little bit more about exercise in a minute, but aerobic exercise primarily, but resistance training, interval training, intervals are like you go really hard for an exercise at 30 seconds and then you rest for 10 or 20 seconds, or go hard a minute and rest and do that over and over again. Now, that exercise isn't for everybody. And I think it's really important to know some of these other approaches you might combine as well. But when it comes right down to it, you have to learn how to manage these things yourself. So energy management. Plan in your day. Try to schedule activities, more strenuous activities where you have the most energy. It varies for everyone, but most people have more energy earlier in the day, or maybe you have energy after a nap, or as well as taking naps and planning breaks during your day. Heat stress. We might be headed for a hot summer this year. I'm kind of getting that sense after the winter we had. But so staying cool, keeping yourself cool, even if that's just drinking ice water, if you're exercising, wearing a cooling vest. By the way, the MS Society can get you a cooling vest if you don't have one. So reach out to them. They have money available for things like that for you. And otherwise, you might find, again, that listen to your body and just really plan your day around your energy level that day. Be flexible. And today may not be a good day. Tomorrow could be a better day. That's kind of how MS fatigue goes. Now, if you are going to develop an exercise program, very, very important hack here would be to make sure that you're exercising appropriately for who you are, whether it's your MS, or whether it's deconditioning, maybe there are other medical problems. So it's really important to check in with either your doctor or a physical therapist when you're thinking about developing an exercise program for your fatigue or for anything else. By the way, besides fatigue, you know what exercise is really good for in MS? So somebody said depression, I heard it. 20 milligrams of Prozac a day is roughly the equivalent antidepressant effect or the equivalent to daily cardiovascular exercise, both for preventing and treating a depression. So cognitive improvement, if you have cognitive problems, besides sleeping better, what is the number one thing you can do to improve cognitive function? Cardiovascular exercise. Yeah, actually makes you smarter. Mm-hmm. Well, at least for a little while. So then you have to exercise the next day and the next day. So keep it regular and listen to your body. Now, this is an example from the MS Society of Canada of an aerobic exercise program worked out for somebody. So we might try to give blanket statements about you should do cardiovascular exercise every day. Great. But not everybody can, not everybody should. So your exercise program should be tailored to you. And somebody who knows you well, your doctor, honestly, neurologists aren't really the best people to tell you how to exercise. I have a little more experience with that than probably most, but I'm not as good at it as a physical therapist is. My wife teaches group exercise at the YMCA. She knows a lot of stuff. She doesn't teach it people with MS necessarily, but she knows a lot more about it than I do. So use those resources that you have, whether it's a physical therapist, an occupational therapist, if you're talking about, and this is for exercise, but occupational therapists can be very valuable in helping you plan your life, organize your life, various tools to help you manage the fatigue that you have and live with the fatigue that you can't manage any better. So here's our little neuron exercising, smiling and happy, and using appropriate assist devices. Scooters are great. Scooters should be used to conserve your energy so you can spend it when you get to where you're going, right? I see some people using scooters and they probably need a power chair. I see some people using gait aids the wrong way, or maybe they're using, you know, those quad cane, those 4-prong canes. Those are for people with strokes who need to lean on them. They're awkward for someone with MS to use if you have a balance problem. A quad cane, you catch the edge of those things, could actually trip you up and make you fall. So any device that you use, make sure it's appropriate for you. Your physical therapist or your occupational therapist will be able to tell you that. These are very important people to have in your lives if you're living with any disability from your MS. All right, here is the consummate busy slide, a lot of information here. So exercise. You do want to make sure your exercise routine is appropriate for who you are, where you are in your physical condition. Maybe you have no problems at all from your MS or very, very mild. But if you're not physically conditioned, you need to have a gradual increase in your exercise program. If you have, again, especially if you have other medical problems. You're getting a lot of exercise in your daily activities, organizing those activities to maximize that exercise. Conserving your energy where you need to. Medications we talked about already, assessing that. Might even be necessary to have you see a dietitian or nutritionist to say, are you getting enough calories? Are you getting the right type of calories? Are you getting the right mix? So, and stimulants. Stimulants are great, right? But when you take a stimulant, caffeine robs energy from the future to give it to you right now, okay? Not to mention what it does to your bladder and a few other things. So caffeine can be helpful. Cheers. I have one of those tomorrow morning, but not tonight, even though I got to drive back later. As he has, is that decaf or are you going full calf? Uh-oh, high octane, he's going for it. So caffeine, case in point. So caffeine can disrupt your sleep. Even if I used to pride myself that I could do an espresso shot after dinner at 11 o'clock and still get to sleep. But my sleep wasn't normal. I didn't feel rested the next day, although it might have been the alcohol before the espresso shot. Alcohol, another one, totally disrupts your sleep cycles, your sleep-wake cycles. So really, many people with MS gradually just stop drinking for whether it's maybe it makes their balance worse. I think often the fatigue impact when it's disrupting your sleep. Brain fog, all of these are things you can do, but sleep. And of course, your mental health. Depression can come out and be mostly felt as fatigue. You may not have a depressed mood, you may just have physical symptoms. So very important to think about all of these things as part of a management plan for fatigue. Well, here's my AI cartoon of, I don't know if that's what pain feels like to you, but there are many pain syndromes in MS we need to understand. They all come from kind of different things. So I think we have to look at the different pain syndromes, especially when we're thinking about how to manage pain in MS. But now here's where I got to tell you just a little bit of a story on myself. As a first-year graduate from a neurology program, I went to work at the Oxygen Clinic in New Orleans, and I was, I think, probably one of the first, second, third, or fourth MS patients I had as like a full-fledged neurologist. This young man came in and sat down. I vividly remember he sat in the chair. My desk was here, his chair was there, and he started describing to me. It's the first time I'd seen him actually. And he started describing to me. I said, "Well, what is it? Can I help you with?" He said, "Oh, this pain." And I go, I just finished my training, right out of neurology school. You're supposed to know everything you're going to know about neurology right out of neurology school, right? No. And even though we had an MS training program, MS specialist, New Orleans didn't have a lot of people with MS, not like Minnesota, although it turns out that we did. They just weren't being counted. If we think about MS in the people of color are horribly undercounted. And New Orleans has a lot of MS, but they're just not They weren't being seen in the clinics. So this young man came in and said, I really need help with this pain. And I said, what do you mean? You have MS? He says, yeah, and it really hurts. And I go, well, it tingles? You mean you got pins and needles? Oh, you're having Lermite sign when you flex your neck? No, I hurt deep down. I hurt everywhere, but deep, deep down in the bones. And I said, nah. I mean, I told you I'm calling myself out here. It was my ignorance. Thinking that I knew everything about MS because I just came out of neurology school, right? I should. Yeah. So now I will say we've come a long way in the world of neurology, of understanding MS and understanding pain in MS. And I can think back about a few things I'd like to take back. I never saw that young man again, and he did the right thing. I wasn't there yet. I didn't really understand what was going on. Now, unfortunately, in New Orleans, he didn't have anyone else to go see. There wasn't really anyone who knew any more about it than I did, sadly. It's different now. Many neurologists now, there are a lot more specially trained neurologists in MS, fellowship trained in MS, but still there's a lot of ignorance out there about the symptoms of MS. So, pain. It can come from, so we need to differentiate neuropathic pain, pain that comes directly from some involvement of a nerve cell. This will have certain characteristics. It'll be sharp, it'll be jabbing, it'll be electrical, it'll be tingling. We call it allodynia, burning, like you feel like that previous cartoon when you feel like you're on fire, or a light touch or even a breeze on your skin is painful, it hurts. And often these symptoms are more prevalent at night. And they may be, and we have to also think about the pain. There's several other ways to think about acute pain syndromes versus more chronic pain syndromes. So paroxysmal pain, acute pain syndromes. Some of you, has anyone ever had trigeminal neuralgia here? Yeah. Did you kind of feel like that? Like a lightning bolt was, yeah. I thought that cartoon was pretty good. So ChatGPT nailed that one. So yeah, that's kind of what having trigeminal neuralgia feels like someone stabbing you over and over in the side of your face. Now, trigeminal neuralgia is probably an inflammation of the trigeminal nerve at the base of your brain. Lermites, when you flex your neck like that, and you stretch your spinal cord, if you have a lesion, especially an active lesion at the top of your spinal cord, and you flex your neck, it causes an electrical or a sharp or shooting sensation that jolts right down your spine or right down your back, sometimes down your back or down your arms or down into your legs. And that's called Lermite's sign, named after the, I think he was a neurologist, we didn't have neurology back then, the French doctor who first described it. There are other things that happen besides spasticity. Dystonia. So spasticity is when a muscle is disconnected from its nerve supply. Muscles just contract when they shouldn't. Dystonia is when your brain is sending signal to your muscle to contract, but the signal gets corrupted. So it's telling different muscles to contract and not in concert. Writer's cramp is a type of dystonia. Wry neck, someone has a neck over like this, that's a type of dystonia. That's where the brain is actually sending signals to fire muscles in the wrong way, where they're not working well together. And that can be really quite painful. Optic neuritis, I didn't mention glossopharyngeal neuritis. There's a nerve in the back of your throat that might give you horrible pain, literally in your throat, in your neck, but inside. Optic neuritis, inflammation in the optic nerve. Usually you have some vision loss associated with that, or it hurts when you move your eye from side to side. So these would be some of the different causes of acute pain syndrome. So optic neuritis would come on fairly suddenly. The trigeminal neuralgia can come on suddenly, comes on in these sudden spasms. And then dystonia kind of comes on. So these are acute things. They come on quickly. They might even go away quickly. They come on quickly and they can even stay around, or they come on and they go away and they come back and they come back and come back. So that would be more of the acute pain syndromes. Chronic pain syndromes, we have to think a little bit, both MS and also think about secondary pain, because if you have back pain, that may not be directly related to a lesion in your spinal cord. If you have back pain, although it might be indirectly related to your MS, if your MS causes you to walk differently, Or I see many people, back to my earlier comment, if you're using a walker, make sure that walker's set up for you. I see many people with a walker where they've been over like this and leaning far forward. You're putting a ton of stress on your low back by doing that. Maybe you need your walker up a little higher, or they have stand-up walkers. These are things that an OT or a PT can help you decide what's best for you. So using both the right gait aids, but also understanding that besides the direct impact of MS, there's the indirect impact of MS that might be causing or contributing to your pain. If we look at some of these neuropathic pain syndromes, I think dysesthesias is probably the medical term for this. This is that sort of uncomfortable sensation where it actually hurts if you lightly stroke your skin. If it burns, we call it allodynia, but you might have a burning, tingling, could even be itching. Anybody had that as an MS symptom where they just sort of itch and there's no rash and no apparent reason for it? That'll make you a little crazy, right? I mean, you go to your doctor and you go, well, I don't see anything, itching, but that can be a symptom. That can be a neurological symptom. So the other dysesthesias, they can vary from being totally disruptive where you can't get to sleep to just mild inconvenience and annoyances. Typically, we don't see acute pain as being part of a relapse. Occasionally, you might get something like radicular syndromes of the spinal cord relapse where you have sharp shooting pains that go down an extremity. That's more like we might expect to see someone if they had a pinched nerve or something, but occasionally you see something like that develop. Now, the MS hug, we get into what I would describe, I think what we call central pain syndromes. So the MS hug is a really peculiar thing. It usually happens because of a problem in the spinal cord. Everybody know what that is? A hug, you probably heard of it. I guess probably the thing when I have someone who's describing something that might be it's called banding pain or central pain syndrome. When I have someone who's having those symptoms and trying to describe it to me and struggling a little bit, I will often just say, does it feel like someone took saran wrap and just wrapped it as tight as they could so much that it hurts, like around your trunk or your arm? And that description seems to resonate more with people. Go, yeah. I'm sure you probably have your own descriptions and some of them might be colorful with a few expletives, but it is a very, very uncomfortable thing. Tell you a quick story. I have a cousin, my wife's cousin, who is on Friday going to see one of my friends and colleagues in Philadelphia, who they suspect she has MS. And she has been going from doctor to doctor, try to understand what this tight feeling was around her trunk. She had a few other symptoms in probably 4 or 5 years, and then someone finally did an MRI scan. So I'm a little bit concerned. She has central pain syndrome, neuropathic pain, and something's going on in her spinal cord, and her brain MRI is abnormal too. But that is not uncommon at all. You do a sensory exam on someone with a hug, sensation's normal. You look for heart disease. Are they having a heart attack? You look for, is there lung problems? You look for major internal organ issues causing pain syndromes. You don't find anything. One other anecdote. I probably have only had 3 or 4 people die on me of an MS attack ever. MS attacks don't usually kill people. And this gentleman was like 72. It was probably, he'd never been on treatment. He'd been Dr. Shapiro's patient. I inherited him and he was doing great. He came into my office one day, just his routine appointment, and I asked him how he was doing. He said, not so good. I've been going from doctor to doctor to doctor, and they just can't figure out what this is. And he described some more than just the hug, but the hug was one of the symptoms he described, and he described some brainstem symptoms. I directly admitted him to the ICU at Fairview Riverside. I went from my office, you're going straight to the ICU. And he didn't make it. He had a very serious exacerbation in his brainstem, also another one in his spinal cord. You're not supposed to have attacks like that at 72, but you know what? It does happen. I saw a woman today who was 77 years old who had an MS exacerbation. So you're never too old to have an attack. So now the hug is a really difficult problem. Very, very difficult to treat central pain syndromes. They don't really respond to single medications. There's a bunch of treatments we might try, but very, very challenging situation. We're often using antidepressant drugs. We may be 2 or 3 different classes of drugs. Antidepressant drugs slow down neural conduction, so they will lessen the pain by just slowing down the abnormal firing nerve. We have time, I'm going to talk about cannabinoids, which actually have a very interesting effect on slowing down those rapid firing of nerve fibers. Bless you. So again, these acute pain syndromes that we just sorted out, optic neuritis, they can be inflammatory. This inflammation in your neck with just a little flexion, zing. In fact, the 77-year-old woman with a relapse that I saw today, yeah, that was today. Boy, it seems like a long time. It was this morning. She was having a Lermite sign. She had it once when she was first diagnosed 20 years ago, and then she's having it again. None of her doctors wanted to treat her. She had had 4 relapses, and she does have mild MS. And I had to have this conversation with her to say, she's going, well, I have mild MS. Why am I feeling this way? Why are my legs getting weaker and weaker? Why is my bladder not working so well? What's with this electrical stuff now? And it's like, well, this is what mild MS looks like, you know? And I think a lot of our neurologists don't know that. So I still hear neurologists saying, oh yeah, mild MS, you don't need to be treated. Well, this lady's only had 4 relapses over 20 years, but now things are different. And if we had treated her, well, I mean, eventually those things probably would still happen, but we probably would have delayed it, or maybe they wouldn't be as severe. So I think there's straying a little bit into disease-modifying therapies here. We'll talk more about some of the emerging ones later, but there's a lot we don't know about this disease, and there is a whole world of geriatric MS, at least since we have effective treatments now. Geriatric MS, just made that up, by the way, it's not a real term, but we have people aging with this disease in a way that we have never had before. And many people with MS, before we had the treatments we have now, would become disabled, and now we're seeing people more functional, but we're having to learn how to use these medications in older people. Should we just stop treatment because you turn 65? Well, I don't know. If 77-year-olds can have relapses? Anyway, I digress. That's for another program. Stuart will have to come back and do that one. All right. So what about symptomatic treatments for pain? What else can we do about that? So these are the typical classes of drugs that we might use. If your pain, and this is why it's so important to understand the source of the pain. If your pain is coming from muscular spasms, then we want to use a drug that's going to target that. Maybe we use an antidepressant. An antidepressant acts centrally. An antidepressant will raise your pain threshold. So the same amount of stimulus won't be painful. If you're depressed, that same stimulus will be painful. Depression lowers your pain threshold. Treating that depression, whether it's an antidepressant or whether it's exercise or mindfulness or whatever it is that works for treating your depression. Typically, we often need meds, but exercise, whatever helps that will improve that as well. So if we think about anticonvulsants, I mentioned they slow down the neural conduction. The muscle relaxants, whether it's antispasmodics, there's some other muscle relaxants, in particular tizanidine, might have an impact on the MS hug. Even though it's a muscle relaxant, it has other impacts on neurotransmitters in your brain and your spinal cord. We've had an awful lot of, well, not very much research, very little research, unfortunately, but some on cannabinoids in MS. So here is the neuropathic central pain syndrome treatments. And I'm sorry, it's a little blurry. I pulled this out of a pharmacy article, but there's in the second column, you see the mechanism of action of the drugs. So there's a bunch of different ways that these drugs affect the nervous system in order to lessen your pain. We have a lot of tools, but a central pain syndrome is very, very difficult to treat. I'm often using 2 or 3 of these classes of treatments in order to keep that type of pain under control. And of course, the more these medications, doesn't list all the side effects, but the more medications you're on, the more potential side effects you might have and potential for drug interactions. So it gets messy. Sometimes we're causing a side effect, and we have to treat the side effect from the medication that's treating the pain. It just gets really difficult sometimes. All right, so what can you do? Here are some of the things you can do to treat your pain. Physical therapy, working with a knowledgeable physical therapist. Especially if your pain is musculoskeletal, or maybe it's the way you're walking, or maybe you need a different gait aid. These are all things that could help, and a knowledgeable PT can help you with that. Exercise. Exercise has to be right-sized for the individual, but cardio is the mainstay. And then you may have other issues. Perhaps there's stretching for spasticity. Maybe you need to do balance exercises. So we start with a core of cardio that's going to help both fatigue and pain. Now, if you have a musculoskeletal pain and you're exercising the wrong way, you may be making it worse. So again, knowledgeable therapists who can help you develop that exercise program and then respond to what's working and what's not working. So a good PT may not get it right the first time. Maybe they tell you to do something that doesn't work for you. So ongoing feedback. Very, very important that you work with knowledgeable people in this area. Aquatics. For pain management, especially if you have, this is more people who have structural issues. So I'm often advising people who have like low back problems. They have herniated discs, degenerative disc disease, some issue like that. I'm also advising them, or maybe you got a bad knee, and you can't exercise. You can do it in the water. If a weight-bearing exercise is going to exacerbate your pain. And by the way, if you exercise in the water, you don't overheat as quickly. And you won't develop that activity-related fatigue, that exercise-related fatigue. Oh, I wanted to mention one kind of general rule of thumb about exercise. You have to learn to listen to your body, okay? But you don't always get it right. None of us do. So if you exercise and you're tired for an hour, good, you should be. Means you exercise, good, you should be tired for an hour or so. If you're tired for 2 hours, well, okay. If you're wiped out for 4 hours, you did too much. If you're wiped out in the next day, you did too much. But did you hurt yourself? Did you make your MS worse? No. Maybe you lost a little time, but you didn't make anything worse. So listen to your body. Don't be afraid if you push too hard. You won't hurt yourself, but you might, have to hunker down for a while till you recover a bit more. But that's a kind of a guide you can use to say, oh, I listened to my body that day and then I did this much exercise. It's like, ooh, that was too much. So next time I listen to my body and saying the same thing, I'm going to do just a little bit less than that. Okay. So that self-correction and adjustment, paying attention to yourself. And doesn't have to be you. If you have a support partner, care partner, someone who can exercise with you, someone who sees you, we don't always have good insight into what's going on with ourselves. So it's good to check in with someone who's close to you. Maybe there are other things. We talked about alcohol, sleep. Hopefully nobody smokes. Smoking is so bad for MS. It makes the immune system more aggressive. Smoking increases the aggressiveness of autoimmune disease across the board. There might be other things that work for you. Acupuncture, heard about that. Acupuncture can certainly help people. Massage therapy, various other physical measures. We have time for this? Maybe quickly. So I just pulled these slides out of another deck that on cannabinoids. A couple of things you have to think about cannabinoids. There are two components of the cannabinoids, cannabidiol and tetrahydrocannabinol, THC. THC makes you high. CBD doesn't. Higher doses of CBD might make someone a little fatigued or might worsen their fatigue. 5 milligrams or so doesn't tend to do that. People who are doing 10 milligrams or more, 15 milligrams, definitely you might have a little bit of fatigue. But there are various different parts of the cannabis plant, but ultimately in Minnesota we have a medical cannabis program, and pretty soon we're going to have a wild rest of recreational this, that, and everything else. So get ready. I've seen what happens in other states. It gets a little crazy. This I'm not going to belabor anymore other than to say there is a natural system inside your brain, the cannabinoid system. It's not just in your brain. You have cannabinoid receptors on your white blood cells, on your immune cells. Why? We don't know. Does cannabis have something to do? Does it treat MS in a different way? We don't know. We haven't been able to study it much. So there are these receptors. This is very complex, showing two nerve terminals. This is the terminal that is sending the signal. When these are chemical messengers going across this cleft to stimulate this nerve to propagate the signal onto the muscle or wherever it's going. If these neurotransmitters are overstimulating this nerve, immediately cannabinoids get released, they cross over here, and they immediately shut that down. Has anybody had that experience where they used a little CBD on something that was burning or tingling, and it's sort of like it got better like so fast that, no, that can't be, I'm imagining that. It works. We can see that it does this with neurons. So there are other things we can use for it. It's not free and clear. Bad things can happen. Cannabis use disorder, hyperemesis syndrome. About 8% of people have uncontrollable vomiting when they take cannabis. So it's a double-edged sword. People with a potential, amotivational syndrome, sitting on the sofa. Yeah, amotivational syndrome. Schizoaffective disorders, if you have schizophrenia or you're tending towards that, cannabis is not a good idea. And there is some concern that it might reduce reproduction, lower sperm counts in men. And just a few recommendations from that. Smoking has a rapid onset. Oral ingestion comes on much more slowly and lasts a long time. And especially if you're doing something with THC in it. If you want to be high the next day, don't swallow it, okay? It breaks down into a really long-acting form and hangs out in your body for a long time. Use oils, use vaporizers, use things that absorb through the lining of your mouth, not things that you go through your gut. So the oral mucosa, vaporizers you get a rapid onset. If you have sudden paroxysms of pain, a vaporizer pen gets you almost immediate relief within seconds. It will help. Tinctures and drops take minutes, 15, 20 minutes or so. A tablet takes even longer. All right. Emerging therapies. Here's a list of a few things that we have going on. I'm going to go through these fairly quickly. The first thing I want to do is just make a distinction about small molecule versus monoclonal antibodies. If you're wondering why you can't get your Copaxone in a pill, I heard that one numerous times over the years. Why can't I just have my Ocrevus or Briumvi or Tysabri in a pill? Why do I have to get it in the vein? Well, large molecules are too delicate to survive the gut. So these big molecules, just a relative size there, aspirin, a bike, a car, an airplane, these are relative size versus a immune globulin or a monoclonal antibody. So many of our highly effective drugs in MS are monoclonal antibodies, and small molecules are very effective too. We have a new class of small molecule drug emerging. This is a list of them. We've already lost a couple. So evobrutinib, I'm going to talk about just very briefly. And then I mentioned these others. And I believe, which one? Biogen, this one right here. I believe they pulled that. I don't think they're developing that one anymore. And I'm not seeing the Lilly drug being developed. But this is a new class of drug, treats MS in a completely different way. These are enzymatic therapies. We've never had an enzyme treatment for MS before. We've also now had a treatment that impacts the innate immune system. The innate immune system is different. It doesn't adapt. It's ready to attack foreign invaders right away. T cells and B cells learn about foreign invaders and they're ready to attack that invader when they see it again. The innate immune system is involved in MS, and we have seen some fairly interesting things develop from some of these drugs. And our biggest concern is these drugs seem to be addressing our biggest unmet need, which is to help people with slow progression of their MS. Our drugs are very effective at preventing relapses and new lesions on the MRI, but not nearly as effective at preventing that slow progression of disability. Here's one of the drugs we were very high on, evobrutinib. This was its phase 2 study, very effective at a 75 milligram dose, dramatically reduced lesion loads on MRIs, and we see a dramatic impact on relapse rates. It clearly was very highly effective treatment. Obviously, you can see the dose, as the dose went up, it got more and more effective. So then it moved to a phase 3 study. Shortly before the data for the phase 3 study was published, this study came out that showed SELs, slowly enlarging lesions, slowly expanding lesions. These are lesions that we see in people with progressive MS, later stages of progression. This drug shrunk those lesions. We had huge hopes for this drug. Then we saw the clinical trial data. It missed all of its endpoints. Missed on MRI, missed on relapse rates, missed on disability. The only thing it was better at, the active comparator was a drug called Aubagio. The only thing it was better at than Aubagio was causing abnormal liver enzymes. So now we have these other drugs in development. We're still hopeful. Enzyme drugs, all our other drugs in MS, if they're in the same class, if you're on an interferon, Avonex, beta-seron, Reba, those drugs all work in the same way. They all have the same side effects, and it's fairly predictable. Enzyme drugs aren't predictable, okay? They may have very different impact. Different drugs can have very different impact. So fingers crossed. At this point, we are very concerned. We have these other drugs coming along. We have 2025, 2026, we're hoping for some of these other drugs. And we'll start seeing some data on these drugs fairly soon, probably into summer, end of the year, and then next year, year after. I'm going to go over this pretty quickly. Tolobrutinib is one we're waiting on, and it has a primary progressive research study as well, and then a non-relapsing progressive study. So this is a development program of this drug we're waiting on, fingers crossed. And then our big hope for a monoclonal antibody for the future is a drug, this particular drug, which impacts B cells, but it does it in a way that doesn't kill the B cell. Now, our drugs like Ocrevus, Briumvi, Kesimpta work on B cells, and if you kill the B cell, we run into issues where you don't respond as well to vaccines, vaccinations. There might be some other immune suppression that develops from that. This doesn't really deplete them, but it blocks both the adaptive immunity, but it also blocks the innate immune system, just like the enzyme drugs do. So we're very hopeful for this one. It's just now entering phase 3 study. And then this was early, I'll just say, summarizing this, the early data is very impressive, and it doesn't deplete lymphocytes. It doesn't lower lymphocyte counts. All right, CAR-T. What did I say? Look, but what did I say at the very beginning? CARs. So CAR-T therapy is a process by which we take a T cell from your body, we train that T cell to go hunt down, now we're using it in cancer right now, to go hunt down cancer cells. And then it lives and it goes on, it continues to hunt them down. So we're just starting very early therapies in CAR T cell therapies for MS, or very early studies in CAR T cell therapies. I'll draw your attention to the diagram there, the cartoon, because I did tell the model to develop a cartoon for CAR T cell therapy. Anybody see the mistakes? There's a car. There's a car. There's one right there. Someone else pointed out there's part of a car right there. It's like, I mean, okay, I'm okay with like, okay, there's the T cell, and it's got also things, and then all these injections. What's a car doing there? AI is not ready for prime time. That's my ultimate decision. So anyway, a couple references for that, and drop the mic. How did I do, Stuart? I'm a little bit over. 4 minutes over, Stuart.
You did great.
He's never going to let me live that down. It was, thank you. It was that one time in Sioux Falls where I talked for...
Oh my gosh.
almost 2 hours.
The first time we had him speak, I asked him to speak for 45 minutes. Well, 2 hours into it, I was like begging him to stop already. and people just wanted to go home.
Everyone got their money's
So
worth.
we've got a lot of online questions.
Fabulous.
A lot.
I love it.
All
Bring 'em.
right. We've seriously got at least 15, but we're going to ask you about 20 something.
Bring it.
Okay.
I'm ready.
We are.
I'm not
How
afraid.
about here? Anybody have a question here, or are you going to wait for me to get started here?
I'll warm them up, Stuart. Go
First
ahead. Warm 'em up.
one. First one, then. I'm going to go first, all right? First one is biomarkers.
Mm-hmm. That's all I
You
want.
don't get that.
Mm.
Biomarkers.
Mm.
So the word that's out there right now is what we're hearing most about is the sniffle, better known as serum neurofilament
Serum
light.
neurofilament light chain.
Okay,
Yep.
so can you tell them about that,
Yeah.
please?
So that is a protein. Serum is where it's found. Neurofilament, it's a structural protein that belongs inside of a nerve cell. So if we're measuring it in the serum, i.e. in your blood, it shouldn't be there. So this is a protein we've known about for decades, in that we could measure it in the spinal fluids of people with MS. Well, not just MS, unfortunately. That's one of the problems with it. It's not specific to MS. If you get a concussion, anything that damages or kills brain cells will cause it to go up. So it's not specific to MS, but it's useful in MS because it will, if you have a relapse or something that's killing off some nerve cells, that protein will be higher in your blood. As I said, we've known about it for a long time, but we can only measure it in the spinal fluid. And so show of hands, volunteers who would get a test that requires a spinal fluid twice a year. Yeah, no hands, right? Okay. Yeah, that was really the problem. So when the technology evolved to the point that we could measure it in the blood, then it became useful. So we now have a commercially available test for for neurofilament light in the blood, or sniffle, serum neurofilament light. We're tracking this in our patients typically twice a year. It will go up when someone has a relapse, so you kind of need to know what it is. It does increase a little bit as we get older, but if you know what someone's baseline is, if they're you're testing it regularly and then suddenly it goes up. So if you think someone's having a relapse, it's something you can check and maybe help confirm that. Good
Thank
question,
you.
though.
Next one is what drug was mentioned previously before Freximab that seemed to help people with secondary progressive?
Oh, the whole class of the Bruton's tyrosine kinase inhibitors that's our hope. And the reference to secondary progressive was more related to what we saw in some phase 2 studies where progression of disability in a group of patients we would have expected to worsen over a couple of years hadn't really worsened. And then the study I showed where the SELs, the slowly enlarging lesions that are characteristic of people with progressive disease, actually reversed. So I believe it was probably one of those drugs. If they want to send another question through, I'll try to identify it more specifically.
Okay, thank you. Next, you had a slide up that said RMS, and on that same slide it said RRMS. What are you showing as a difference?
As a typo. Point being, though, that I don't do the RRMS because the second R is remission. So
Remitting.
Anybody here think they're in remission from their MS?
That gets us to the next question. Let's talk about smoldering MS.
Mm-hmm. So smoldering MS is not a new concept. There are a couple new terms. There's something called PIRA, progression independent of relapse activity. This is someone who has relapsing MS, but they're not having relapses, likely due to their disease-modifying therapy, but they're still slowly worsening. Their MRIs may not be changing, although if you do specialized MRI techniques so you can see those SELs, I'm working with the radiologist we use to develop a way to measure the SELs. They're not seen on conventional MRI imaging. You have to do special techniques to see them. But those SELs are a hallmark of progressive disease, and we'd like to be able to track those.
What's an SEL?
slowly expanding or slowly enlarging lesion.
Okay.
So
Great.
and that was in the.
I'm sure they want to know that too.
Mm-hmm. Yeah.
Okay.
How do you differentiate slowly progressing in terms of your MS getting worse, or is it your aging?
That's the crux of the biscuit in the whole geriatric MS thing I just made up. It's really hard to tell. Now, there are a few really important tools. I, as a neuro-ophthalmologist, I have an ability to, or experience with using a technique to measure brain cell densities at the back of the eyes. We know how quickly people should be losing nerve cells due to aging out of their retinas. The brain's a different story. We know how quickly the brain should be shrinking, but it's just really hard to measure. MRIs are not very sensitive for that. We have to sort of eyeball it and look and see, is it shrinking faster? Volumetric software can actually measure brain volume change over time. So that's really very important. And go ahead. No, you got more. You got 15 questions.
Person is asking more about the smoldering. They want to know what DMTs might be good for the smoldering MS.
Yeah, that's why we're hopeful on these new classes. And let me expand on that a little bit. There's the smoldering or PIRA, and then there's also a relapse associated worsening. So divide those two. And then people who aren't having relapses have what we used to call secondary progressive MS, and now we're lumping that into a non-progressive or non-relapsing MS. So this relapsing MS versus non-relapsing MS, we're starting to evolve more and more of a concept, and even primary and progressive is a non-relapsing form of MS, although it's a little bit different in terms of the treatments it responds to. We're very hopeful. We have one drug approved to treat primary progressive MS, and it's moderately effective, reduces roughly about a quarter of the progression, but it's a big unmet need, and in our non-relapsing progressive MS patients. So again, we're been really hopeful for these BTK drugs. Hopefully the next couple will be good, and then as we invoke treatments that impact the innate immune system, we're hoping to hit more of that progressive part of MS, but that is our biggest unmet need.
Thank you. First question from the audience.
My husband had relapsing remitting MS, had been treated with Rebif for a number of years. He aged. He had been clear for 8, 10, 12 years. Recommended, because he was over 65, to stop the Rebif. For whatever reason, age was part of it, we were told. And it kept him all those years from having any new lesions. Well, within 6 months after being off the drug, he started progressing with the symptoms and was diagnosed then with a secondary progressive, I guess is the term. So I know in listening to you, it doesn't sound like there's anything out there for that type of MS. And it sounds like this new group you're talking about may be part of this progression, but you've also changed the terminology, if I'm hearing right, from secondary progressive to something else.
Yeah, we changed the name, but it's still the same old stuff. And I think we see this periodically as the academics will publish and come up with better ways to kind of think about something, and it just changes the name. But so you hit on a very, very kind of hot topic right now. We are based on not really great data. There's this groundswell to recommend stopping treatments in people with MS. We have spent decades researching when to put people on, who should be on treatment and who shouldn't. We have very little research and very poor quality studies on should we stop the treatment. Now, one study called the DISCO MS study, a friend and colleague of mine in Colorado was the driving force behind this study. And it took people over the age of 50 who had been relatively stable and just randomized them, discontinued kind of half of those people. And actually, as a group, the people who were discontinued worsened more. The study was considered a negative study in that the study was designed as what we call a non-inferiority study. So all it had to prove, it just had to prove that stopping treatment was just as good as staying on treatment, failed to do that. But because there was a small group of people who worsened, it's now being said that, well, we should be stopping treatment in people just based on age. And I think it's a really slippery slope here. We don't really understand what's going on here. And that's why I honestly didn't just make up geriatric MS today. I did it a couple weeks ago, a couple months ago. Maybe someone else has already coined it, but this is a big, big problem. If someone's aging and they're slowly worsening, and we're calling them progressive, well, if they're on a treatment, our treatments are very effective at preventing relapses and new MRI lesions, and probably effective at slowing some of the progression, just not all of it. If we're going to call somebody non-relapsing progressive, implying that the treatments aren't going to work, therefore we should take them off treatment, how do we know that the reason they're not making new MRI lesions or having relapses isn't because of the very medication that they're on? So really the only way to know if someone is non-relapsing progressive is to do just what happened to your husband, is discontinue the treatment. And if they get worse, well, the treatment was doing something. Then we put them back on treatment, but they don't catch up to where they were before. So that is the risk that we take with people when we recommend that they stop their treatment. Now,
the problem with that was when we had the discussion, what happens if he has relapses? It was, well, then if it's within a year, you go a year to 2 years, you can go back on the drug. Well, he didn't have the new lesions, but he was relapsing with a change in his symptoms. But because Rebif was for the relapsing remitting, he couldn't go back on the drug, and there weren't any other drugs to put him on to prevent the progression.
can we talk after? This is, I have seen what's happening to your husband happen over and over again to people who, some well-meaning neurologist, discontinue their treatment based on the recommendations. We have to understand where these recommendations came from. This was kind of a made-up thing by the FDA, really. So this non-relapsing progressive concept, we still don't know what we're doing with the whole aging and MS thing, and we need to learn a lot more and just blanket discontinuing treatments. Now, I agree we have to manage the risk of our treatments. So de-risking the therapies. On Rebif, it's hard to de-escalate. I mean, you could, Rebif's a pretty safe drug, so I guess I would be concerned why. We'll talk more afterwards, but it's a relative risk and relative balance thing. So let's just have a conversation after that.
Thank you. Next question.
Okay.
By the way, before I get to the next question, there are a lot of doctors, I'm going here and then going around. There are a lot of doctors in the U.S. that just believe that the best time to stop taking your medication is when you're, unfortunately, after you die. That's the time to stop taking your medication. Yeah, in other words, just keep on going. Yeah. And if your doctor wants to switch you off of it, go find another doctor.
Going back to the first question that was posed as far as the serum markers, discussing with another neurologist in Canada, one of the projects that they were looking at as a hypothesis is that there is a tie to initial triggers of MS due to trauma. Have there been any looks at that for looking at those levels post-trauma? It's one of the biggest things is the initial diagnosis of MS.
And you're talking about neurofilament light specifically in that context of trauma, or I didn't?
Yes.
Follow. Okay. Yeah. So we have studied this. There have been various sort of anecdotal reports of someone having significant major physical trauma as well as emotional traumas. And we do see in people who have MS established, we do see a slight tendency to have an increased chance of having a relapse. These tend to be major stressful events, death of a spouse, change in job, major things, pandemic, stuff like that. So I'm not as familiar with all of the cutting edge data. Was a specific neurologist, a Canadian neurologist you were talking about, or? Don't know. But so I can't really answer your question fully on that. There might be some data I'm not aware of, but we have looked at this. And is he postulating an interaction between neurofilament light, or just saying that the trauma and rise in neurofilament light is the
general hypothesis that we were discussing was that there is the possibility of a genetic predisposition to MS,
Sure.
which is triggered by a severe either physical and or emotional trauma, anything from a car accident to an emotional trauma within there, that within 6 to 12 months following that trauma, the initial MS symptoms arise out of there. And I was wondering if there was anything that had looked at that potentially could show those increases in those biomarkers due to that to potential cause to an MS.
We're on the cusp of developing a lot of biomarkers for MS, not just the neurofilament light one. So I can't fully answer your question there, but I think we are aware of the impact of physical and emotional trauma, whether it outright causes MS. Is it another trigger, like Epstein-Barr virus is a trigger for people who are genetically predisposed? So I wouldn't rule it out. I'm unfortunately just ignorant of that particular research that neurologist is talking about.
I would just like to add a plug. If you're really interested in research, if you go to the research section of our website, you can actually sign up for research updates that you can get regularly, and you can do some pretty comprehensive searches for those things as well. And then also maybe visit Pathways to Cures, which is our the global consensus for things that are happening across MS societies across the globe. And those are, if you really are into kind of soaking in that research, to check that out, and you can even just kind of get those updates pushed to you.
It's a whole nother big subject.
Yeah. But it's a great resource for people that have questions about research and want to kind of take a deep dive into it. And then the other thing I would just add is that there is a huge prevalence of multiple sclerosis among veterans. And we have a huge partnership with the Department of Defense that's funding the MS Research Project to try to unpack some of those things that go along with what are the components of being a veteran or being exposed to war. So there's a lot of research being invested in that area. So just thought I'd put a plug in for people who want to learn more.
Exactly. Thank you.
When do you know when you should change your MS therapy drug? And can you get immune to the one that you're on?
Hopefully your neurologist is helping you with those decisions. But I will say often the patient knows it before the neurologist does, although the patient may not want to admit it. Essentially the conventional ways that we track response to a disease-modifying therapy is just kind of crude tools, really. The neurologic examination, not really very sensitive. MRI is probably one of the more sensitive things in the brain, but even in the brain, it doesn't pick up every new lesion that happens. And in the spinal cord, not very sensitive at all. In fact, one of the reasons we do regular neurologic exams is because of the weakness of imaging in the spinal cord. So we're much more likely to find a change in your exam, or you would notice new symptoms of something that happened in your spinal cord compared to something in your brain. Much more likely to be silent if it happens here. So the MRIs are good for tracking the silent lesions that may be occurring that you wouldn't cause you any symptoms, then tracking your symptoms. If you do have new symptoms, the general rule is if you have any new symptoms lasting longer than 24 to 48 hours, you should reach out to, at least that's our rule in our office, you should reach out to us and let us know. We take some information. Maybe it's not a relapse, but we want to investigate and know more. So relapses, new symptoms, changes on your neurologic exam, changes on your MRIs. Now, none of those things are completely sensitive, so we use all three of them to try to capture more. But let's add a bit more. So one of the things I monitor is brain cell densities in the back of the eyes with a test called an OCT. We also monitor contrast vision. This isn't a typical black letter on a white background. It's a dim gray letter on a white background. That is something that's been correlated with changes in the optic nerve. If you're having changes in the optic nerve, it's your MS. So if you lose 7 letters on a contrast chart test between exams, something significant happened in that eye. So these gross, crude tools that we have, then layering on more sensitive things, and just what we try to do is measure. None of the tools are sensitive enough, so we try to measure everything we can measure about the disease when someone's on a treatment. Another important thing to do is understand that our treatments don't become effective right away. So if we initiate a treatment and then you have a relapse 2 months later, we don't throw the treatment away over something like that. It needs more time to work. Same thing if you have a new MRI lesion in the first 6 months or so of a treatment. So often we will do a new baseline. We initiate a treatment and we do a new baseline of imaging and neurologic exams once the treatment's had time to become fully effective. Then we have a good baseline to compare to. Biomarkers. Neurofilament light is a problem because it goes up and goes down and goes up. It'll go up with a relapse. GFAP is another marker we don't quite have. I think there is going to be a commercial test available for it right now. That's a biomarker, a protein of the, actually, I guess it's the immune system, that correlates with people who have progressive MS in a similar way that the slowly expanding or SEL lesions do. So those would be some of the ways that we would use to try to identify that. And then you are the ultimate arbitrator of whether your treatment's working or not. However, if it's fatigue and what you really need is thyroid treatment, so our job is to sort through those things that might be causing you to worsen and make sure what's causing you to worsen is your MS, and then we take steps. Yeah, good question.
Can you tell us about the status of myelin repair medications?
It's depressing. A lot of hopes for that. So we've actually been able to demonstrate myelin repair in the visual system in the optic nerve. This is actually a commercial, it's not commercial yet, it's in research stages. But even though we can show that the optic nerve conducts better, and as a direct result of the treatment, it remyelinates, we can measure that, didn't make any difference in people's vision. So it didn't, and so the remyelinating therapies so far are showing glimmers of hope and promise, but they're just not making a difference in people's lives, at least in the research studies. So we have a lot of interesting things, and I'll just draw your attention to a couple things about remyelination. We know there are some things that remyelinate in the animal model of MS. One of those things is vitamin D, promotes remyelination. Another one is one you've been hearing about a lot in the news of all the people who want to live forever, taking metformin, the diabetes drug. Metformin causes these lab animals to turn on their oligodendrocytes and start making myelin and remyelinating damaged nerve cells. There's I forgot the name of the antihistamine antidepressant, Tavist. What's in Tavist? There's a clemistine. So there's an antihistamine sinus medicine called clemistine shown to remyelinate, but we haven't got to the point where there's enough remyelination to make a difference. There's one other thing very important. In order to remyelinate a nerve has to still be there. MS kills nerve cells. So let's end on a high note. Let's put a question on a high note.
All right. Going back to PIRA, person wants you to re-explain that. And also, is it true that people over 60 automatically progress out of relapse stages into something else?
So that one's easy. No. Last one first. No, it's not a slam dunk that anyone's going to develop progressive disease. But a likelihood that someone with MS is more likely to worsen faster than aging, even best case scenario. So what was the first part of the question, Stuart? Sorry.
PIRA, to explain it.
Yeah, so PIRA would be just that of someone. So PIRA could be, strictly speaking, progression independent relapse is someone who has relapsing MS still. And we are at least masking the relapsing aspects of the MRI changes and actual new symptoms of relapses, but they're still just slowly developing disability. And it probably has a lot to do with, when it's especially physical motor disability, it probably has a lot to do with long-standing damage in the spinal cord. And then the cognitive issues are probably one of my biggest worries about progression is cognitive progression can be going on very slowly and really, really hard to tell. That one's really tricky to measure. And it's really important and to prevent that if it's going on. None of our treatments are great at it, although our current relapsing treatments can have at least some effect on slowing it down. But like I say, these drugs we're hoping for in the near term, we really hope one of those is going to make it and be successful for that PIRA aspect of MS.
Great, thank you. Now let's continue with another acronym. Tell us about NEDA.
NEDA, it's my favorite. Anybody know about NEDA?
No evidence of disease.
We have NEDA All-Stars at the Minnesota Center for MS. So what's a NEDA All-Star? Well, first of all, what's NEDA? So NEDA stands for No Evidence of Disease Activity. That's our new target for treatment in MS. So what does that mean? 4 elements of NEDA. So means just those things we were talking about. No relapses, no changes on the neurologic exam, no new lesions on the MRI scan. So NEDA, that would be NEDA 3 elements of NEDA. What I'm really going for, and as the ultimate outcome of treatment, if I can get a patient in a situation where they are NEDA 4 at 5, I will explain that. Those people do really great with their MS. Not that they're not going to have some problems in the future, but they're going to be pretty good for the most part. So NEDA 4 at 5 is no relapses, no MRI changes, no changes on your examination, and no brain volume loss, no brain atrophy, or brain volume loss at the rate of aging. If you hit those 4 things on a treatment, or not on a treatment, at 5 years, data suggests you're going to do great with your MS, and that's our new target to treat. So NEDA, and when I have someone who achieves that, I call them, they're our NEDA All-Stars. That's what we're going for. That's our A team. We want everybody to be on that team.
Great, thank you for that. Next one, interesting question. Many MS medications were being pushed very heavily in the past. And for instance, Tysabri, all right? And yet the doctors all spoke about Tysabri being this great medication. I'm not pushing this one medication for everybody to know. It's just that one came to my head, all right? But what happens to it afterwards? So it's not being promoted anymore by the company, yet the doctors all say it's a great med, so why aren't you still using it?
We still are using it.
You are.
I'm
but there are a
using
lot
it.
of doctors in the country that are not.
So a lot of neurologists, I think, rheumatologists use drugs that cause PML2. They don't spend hours ruminating over it. In fact, they probably should do a better job of disclosing that risk to some people. But in MS, for some reason, we focus so much on a risk that can be quite rare, although very serious, it can be quite rare. So I think Tysabri had that experience of being FDA approved and then immediately pulled off the market because of a very bizarre brain infection. We had never seen that, at least we weren't aware of it ever happening in MS prior to that. And so I think that's sort of stuck in the psyches of fairly risk-averse neurologists. And you know, it's always, you have to balance what the disease can do versus what the treatments can do in terms of risks and side effects. So I think Tysabri is being used. The biggest reason, Stuart, I see is actually patient choice. You know, back when people were sticking themselves with a needle, you know, 3 times a week, every day, every other day, boy, if they had the opportunity to do an infusion every 4 weeks, it's like, oh, sign me up. Now I have a patient I think might do better on Tysabri than one of the other infused drugs, but they go, do I want to do something every 4 weeks, or do I want two and walk away? Sorry, you guys. I know that's your marketing campaign, but sorry, tease them a little bit. But yeah, but that convenience, and they market the drug that way because it's important to people. And you guys are busy. You're trying to have your lives as well as living with your MS and living your best life with your MS. So anything we can do that helps your convenience, that helps your quality of life, including not having you in an infusion center all the time. So I think a lot of times, Stuart, it really comes down to patient choice. And if you have drugs that are close in efficacy, even though one might be more desirable, or even if your doctor, I've even kind of been, I don't really tell people what to take. I lead them to the right treatments, and then we converse about it, and then we make that decision together. But even when I'm sort of leaning in and nudge, you sure you don't want to try that? That's pretty powerful.
Gotcha. All right. It's not my question. It's one I read. All right. Next one is going back to NEDA, no evidence of disease activity. Can you be NEDA and be non-ambulatory?
I suppose. It's not typically how we think about it. But I guess it depends. If someone had a major spinal cord event, and if their MS has become quiescent to the point where it's not active, yeah, sure, you can be NEDA and not ambulatory. Does that happen very often? Probably not, because generally if someone's not ambulatory, short of a few situations where they have some really serious damaging relapses in their spinal cord, usually that ambulation is the impact of many, many years of the disease picking away slowly at the spinal cord. And so people can kind of gradually lose their gait and mobility. So it's uncommon in that scenario, because that's going to be more likely the non-relapsing progressive, the true non-relapsing progressive form of MS. So
that was an awesome question.
Yeah,
that was an awesome. I've never heard that. I've never heard that one asked before.
I haven't heard that one either.
That was an awesome question.
Yeah, it's good. Mm-hmm.
All right.
Kudos to whoever online asked that one.
That's right.
Good one.
All right. So next, going back to ferritin and RLS, can you please discuss that a little bit more?
Okay. So specifically, ferritin is a protein in the blood related to iron metabolism. And you may not even be anemic if your ferritin is low. You're not moving iron around. Ferritin is an iron transport protein. It moves it around, gets it through the gut, helps you absorb it, gets it to the right places where it does what it needs to do. So you don't necessarily have to be anemic, but if your ferritin level, and I think the normal range goes down to around 25 or so, the lower end. But if you're even 75 or below, and some studies even 100 or below, and I think the upper range of normal goes up to around 300. But if you're in that lower range, many people will respond to iron treatment. So restless legs, I'm not sure what part of the question, what aspect needs explained, but restless legs is a very common periodic leg movement of sleep. It doesn't just happen in sleep. It's due to an imbalance of the neurotransmitter dopamine in the brain. And dopamine does a lot of things. Dopamine is involved in Parkinson's disease, so it has impact on movement and movement disorders. And those twitchy legs, it is a compulsion to move your feet or your legs. It's not burning, tingling exactly. It's just like, you just feel like, I just have to move them. And only moving them will make them feel better. So that's kind of the sign of restless legs, and it'll be more common at night, but it can happen in the daytime and be irritating even in the day. There are other treatments besides iron. In fact, gabapentin, I don't find gabapentin works quite as well as the Parkinson's drugs. I use pramipexole because it lasts a little bit longer than ropinirole. And then there's the Sinemet, sometimes I'll use that one too. But any of the Parkinson's drugs tend to work for it, to lessen it, may not stop it. Iron infusions can stop it, but the medications just tend to help it and suppress it, help people sleep better.
So the solution, that's a great solution for that. But let's talk about those that have severe spasticity during the night and their legs totally freeze up on them, or they could be sleeping for a short period of time and wake up to severe pain in a leg, which what should they be doing for that? Is water the answer? Tell us your thoughts.
Yeah, in most cases, spasticity is the direct result of damage in the spinal cord. Stroke, it's different. It's damage in the brain, but in MS, it's usually from the spinal cord. And so when a muscle is disconnected, let's see if I can do that without spelling it this time. When a muscle is disconnected from its nerve supply, the muscle becomes irritable. Muscles know how to do one thing. They know how to contract. A muscle has to be told to relax. And if your brain isn't sending signals to your spinal cord to tell the muscle to relax, it's going to stay tight. Nocturnal, when you're lying in bed at night, not moving, the muscles slowly contract and get tighter and tighter and tighter. The other aspect of a spastic muscle is it reacts against a stretch. So if you suddenly stretch a spastic muscle, it contracts against that. Now, think about walking. If you have spasticity in these big, strong muscles here and weakness in these muscles, anytime you try to raise your foot up, and when we walk, we have to lift our foot to swing it through. When you try to lift that up, that calf muscle is going to contract against it. And then what do? You catch your foot. So spasticity can affect gait. At nighttime, the painful cramps and spasms can be treated. We tend to use a medication called baclofen. There are other medicines we can use for that. Baclofen's an anti-spasmodic medication. There are other things we can do. Besides that, sometimes we have to do Botox treatments, deliver Botox directly into the spastic muscle. Gives pretty good relief for 3 months or so. Can have side effects of weakness, can develop. Not all spasticity is bad, actually. If you take away too much, you might unmask weakness in the muscle. Nocturnal cramps are a real problem. They can come from other reasons besides that. So hydration is important. Potassium, if people are on medications, any diuretics where they're wasting potassium, they'll have a lot of cramps at night too. So we also have to think about that. Not every cramp or spasm in the middle of the night is necessarily MS spasticity. So just your doctor needs to cast a wider net in thinking about those things and looking for other problems.
Okay, thank you for that. Before I get to the next question, there's a person from New Zealand online who wanted me to say that there's a person from New Zealand online. That's a long ways away. I got to thank her for being online.
Ask them if they're on the North Island or the South Island, and if they know Dr. Gareth Perry, he's on the South Island. And if they do, say hi to Gareth for me.
She can hear you, so I'll get an answer from her.
Say hi to
another
Dr.
time.
Perry for me if you see him.
She's actually part of an MS society that's over in New Zealand, so I'm giving her a plug for that.
I don't remember the New Zealand neurologist I met. I sat with her at a conference in Europe, 5 or 6 years ago, but she worked with Gareth. She is on the North Island. I can't remember the name of the towns, but and worked with Dr. Perry. I think Dr. Perry's still doing a little research here and there, but Dr. Perry was at University of Minnesota.
She's being shy and not answering. Okay, maybe she's not listening. Okay. Next question. Going back to the BTKs and the anti-CD40s, how long are we looking at before it passes through its final phases to potentially get on the market?
So we'll see the next BTK data probably end of summer this year, and then I'm not sure if it's going to be ready in time for ECTRIMS, which is in this, I think, second week of September this year. ECTRIMS is the biggest MS meeting in the world. It's a European Consortium on Treatment and Research in MS. So we'll have data presented. Typically, if that data is positive, it'll be submitted to the FDA. And then that will probably take anywhere from a few months, 3 to 6 months or so, maybe not that long. And then the FDA typically gives themselves a year to review. By statute, they're supposed to do it in a year, but they often give themselves another 3 months. So I would say we're probably a year to a year and a half away. And then the next drug, now both of these drugs also have primary progressive and non-relapsing progressive trials going on. So some of the primary progressive data is a little bit behind the relapsing data, so that may come a bit later. The other drug has a kind of interesting research, or the way they designed the research trial was event-driven. So normally, when they design a trial, they say we're going to recruit this many people and we're going to study them for X period of time. Okay, this trial tried to do things a little differently. They said we're going to recruit X number of people, but we don't have an end date to the study. There has to be a certain amount of relapses or disability progression or MRI changes. And when they've had enough of those events occur, then they know the study is statistically powered appropriately. Sorry to get into all the gobbledygook, but so this research study basically is kind of open-ended. If nobody has any disability progression, nobody has any relapses, or nobody has any MRI changes in the study, it could conceivably go on forever. So I don't think it will. So likely 2 to 3 years, we will see our first BTK drug, assuming the next 2 drugs do well in their clinical trials.
Great, thank you. Before I get into the last 1 or 2 questions that I have, does anybody have anything? Okay.
Oh, we got another one over here.
All right, I'll be there. I'll be there in a few minutes. You got to wait for the microphone to get there.
Can you remember your question? Okay.
Okay, great.
Do you remember long enough? Okay.
So before I get to these last few questions, a person online wants to say, Dr. Calkwood is my new favorite MS neurologist to listen to after Dr. Ben Thrower. Please have him do these talks more often. Thank you. Lisa in Warner Robins, Georgia.
Oh, thank you, Lisa. Ben's one of my favorite all time. I love Ben.
Exactly. So. And then also going back, person writes, can you expand your take on cannabis CBD for pain? Make it short.
Expand my take. Okay. So CBD and THC are the 2 components, and there are other terpenes and flavonoids and things we really don't know much about what those things do. So CBD tends to have a greater impact on pain, although one thing about cannabinoids is CBD and THC potentiate each other's effect. So an additive effect would be like 3 plus 3 is 6. A potentiation effect would be 3 times 3 would give you 9 times the effect. So that's what potentiation means. So when you have CBD, if you're taking CBD and you have a small amount of THC, the CBD will work better. By small amount, I mean roughly 10% or so to make the CBD work better. I often am going to start, because there's a lot of individual variation. CBD is going to be better for pain for most people so high CBD, low THC is what we tend to use for pain. Spasticity, CBD will work, but sometimes I find a little higher THC might help spasticity a bit more. And by the way, I've learned a lot of this from my patients. One of our patients, when Colorado went legal, road tripped over there, and I've been learning from her all ever since, and everyone else, my patients who just experiment. And there's a little bit of research on this, and we just sort of learn what to do. But so CBD, so where I tend to start with people, I recommend about a 1-to-1 CBD to THC. If you're naive to cannabinoids, I tend to recommend about 2.5 milligrams of each. And then you can raise the dose up a little bit. Be a little bit cautious. Like I mentioned, hyperemesis syndrome happens. About 8% of people can just really get quite violently ill. It's not a permanent problem, but as soon as the cannabis wears off, it goes away. But that can be one of the side effects of cannabinoids. But for pain management specifically, I tend to go higher CBD. I'll start with a 1-to-1 concentration, and then I will kind of increase the CBD if the patient's not having any cognitive side effects from the THC. If they're getting high from the THC, well, we got to lower that. Well, unless they want to be high, we got to lower that down. So some people, it's part of the bonus. So anyway, so okay. Can you will you be able to remember that question long enough for her to ask hers?
I need to be able to get to you, but I got to take her question first.
Okay, yours is about side effects. We'll come back to you. Just don't lose it.
Quickly, whatever happened to Novantrum? And if you've had any of that, what kind of effect would you have? And is or any proof of MS being hereditary?
Take the last one first. Yes, MS is hereditary, but is not directly inherited the way we think of typically inherited diseases. You inherit a tendency to develop autoimmune disease, and that really is a problem in the problem is it's a defective correction system. Immune systems make mistakes. Everybody's immune system makes mistakes. And people who develop autoimmune disease, the difference is those mistakes don't get corrected. So the genetic predisposition is to not fix those immune system mistakes, essentially. What was the first part of the question? Novantrone. So Novantrone is a drug originally developed to treat prostate cancer. And it is the only drug, I think I'm right, the only drug at this time that is FDA approved to treat secondary progressive MS. It was shown to do that. Now, the study wasn't great, but anyway, it has an indication to treat secondary progressive MS. The time we started using Novantrone, we knew that Novantrone had one fairly serious risk, and that was acute myelogenous leukemia. Mortality rate of about 60 to 70% in some cases. At the time we were using Novantrone to treat secondary progressive MS, we thought that that risk was about 1 in 1,000 of getting AML. Along the way, using Novantrone, and I have to say that Dr. Shapiro I treated about 50 patients with Novantrone. Dr. Shapiro treated over 500 people with Novantrone. And this is over a period of probably 5 or 6 years. And I know of 5 of our patients that died as a result of cancer from the Novantrone treatments. And in fact, one of our patients actually was sad. And it was a poor your time, Kathleen. He was actually on the board of the MS Society. He and his wife, they were both very active in the MS Society. They both had MS, and they both were in power chairs. And I want to say they both got Novantrone too, and they both wound up dying. So I think she died of something else, not cancer related, but he died of 2 cancers. So he survived the first one, and actually his second cancer developed as a result of the chemotherapy treatment of the first cancer. So it's just like, yeah. So Novantrone, I think it's still around, but I don't know anyone using it.
Bad drug.
Novantrone.
It's a bad drug.
Bad drug. Novantrone. Bad drug. Yeah.
Bad. Let's take this question.
Could answer that question that way, right? We'll save time.
Yeah. I'm concerned about the side effects. Seem to be very sensitive to any change in medications, taking a lot of medications at the time. What's safe to take? We've been offered different meds, but experience has told us that you upset the cart, you get one thing wrong, and the whole house of cards comes down.
All times, yeah. So I assume you're talking about disease-modifying therapies, treatments that would slow down or prevent MS, because we also have symptomatic therapies in MS we might be using to treat like the spasticity or the restless legs. Those were symptomatic treatments. Whether you take a symptomatic treatment or not doesn't make any difference to whether your MS gets worse or not. Whether you take a disease-modifying therapy or not does make a difference to whether you're going to develop more disability. Yeah. So side effects are going to be very, very specific to each drug or each class of drug. So a class of drug would be different drugs, but they work in the same way. Interferons, Rebif, Betaseron, Avonex, these drugs all have the same side effects. They have to be injected because they're delicate molecules, can't pass through the gut. But they'll all have very, very similar side effects. So you really have to know more specifics about what side effects you're concerned about. But the principle here is understand that just because all that fine print in the information about the drugs from the FDA that tells you all the ways you could die with absolutely no context to it, that may not be, you really have to drill down on what the most common side effects are with each individual medication. And then your doctor needs to spend time talking to you so you understand those things and ask questions if you don't understand. There are other resources. The MS Society, as Kathleen mentioned, has information available on their website where you can, now that too will be more of an individual list of all the side effects that might happen. What I try to do with my patients is, well, in fact, I do have them read those materials and they read all that stuff and then they come in going, I'm not taking any of these drugs. They're all going to kill me. And then I go through it with them. Okay, these are the most common side effects we tend to see. Now, just because a side effect is listed doesn't mean you're going to get it. Okay. So that context is say, how often does this side effect happen? How is there, and then based on things like your medical history. Some of our drugs might have a problem. If you have asthma, it might trigger asthma, or if you have COPD, it might make that worse. So we have to look at all of the drugs in terms of the side effects, very individual for the person, for that person's MS, as well as that person's other medical conditions.
I would be real reluctant to take anything that doesn't clear your body quickly. We're talking about infusions twice a year, and you get that in your system, and it reacts badly.
Well, you
got to wait 6 months for the symptoms to go away, or what?
No, not necessarily. So I think what you really are going to have to look at each individual treatment separately. We can look at the class and say they do similar things. But I think often people begin missing the forest for the trees. You get so focused on the side effects, you forget the reason we're even talking to you about going on a treatment. Is that, you balance the side effect risk with what's the risk of the disease to you? What's it going to do to you in terms of your disability and your neurological functioning?
Fibromyalgia, is that connected to MS?
Actually, it is a little bit more common in people with MS, although it's not directly caused by MS. But yeah, fibromyalgia is, yeah. Well, you're welcome.
You spoke about Lermite's, you spoke about dysesthesia, you spoke about a few other things, but you did not speak about solutions for any of them. So tell us what you can do to help people feel better from these side effects.
I'll just go through the slide deck again. They must have missed that part. So,
must have.
So essentially, dysesthetic, paresthetic pain, paroxysmal, tingling, burning, anticonvulsant drugs work for that. Drugs like gabapentin are going to work more on paroxysmal pain. Things like trigeminal neuralgia, we're going to use things like carbamazepine. Gabapentin may work. I haven't had as good luck with that, but the anticonvulsant class drugs tend to work best with that. So the things that your doctor can do, which is medications. There are things that you can do, which is more of these things. There's a self-care wellness. They're actually fairly similar for what works for fatigue and what works for pain. There's a lot of overlap. So physical therapy, again, it depends on the cause of the pain. If you're having musculoskeletal pain, a physical therapist can help with that. Spasticity, exercise, the type of exercise may be important. Aquatic, we were talking about more just as far as a weight-bearing thing. So some of these things are the things we talked about earlier. Mindfulness meditation practices actually raise people's pain threshold. You can do that through just simple meditation. And then avoiding things that are going to make anything worse, sleep deprivation especially. So those are a few things. Hopefully that helps to recap what we talked about earlier.
Thank you. I think we have to call it a day. It's getting very late.
Today, so it is.
It's almost tomorrow on the East Coast. All right.
It's tomorrow somewhere.
I want to thank all of our sponsors that were here tonight, whether they were the sponsors of the program, the exhibitors. Everybody means so much for the MS community, and I want to thank all those that did this tonight. I want to thank Dr. Calkwood, Kathleen. I want to thank you. I want to thank the National MS Society for all that you do and all that you do to help MS Views and News in rural America. So I want to thank you for that. Dr. Calkwood, I can't say enough about you, which is why we continue to use you. All right. Thank you, everybody, for being here.
Thanks. Thanks, Trevor, for coming.
Of course, I have to thank our audience, because without you all, we can't do programs.
None of this would be possible. Without all you guys,
That's right.
none of this would be possible.
Without you all, it's not possible. And I have to thank my team as well. So we live and we go forward. Thank you.